Well, thank you everyone for coming out tonight. I'm already breaking the rules here. Robin said there's no drinking allowed, so I'll kind of put that away. And really a special thanks to Robin and Christine, who really set up this educational seminar. They put a lot of work into this. And just to get an idea, how many people here have been to one of our previous prostate cancer seminars? Have there been some? So yeah, a few people here. So for some of you, some of this may be review, although there is some new things that we'll talk about tonight. For everyone else, hopefully this will be a good, broad overview about prostate cancer and a lot of the issues that we face with prostate cancer, and provide some good education this evening. Just to go over some of the objectives tonight of the discussion, we're going to talk a little bit about just some general background information about prostate cancer. We'll discuss how prostate cancer is diagnosed. We'll discuss the risk stratification of prostate cancer patients. So today we have a very good understanding that prostate cancer is a heterogeneous disease. There's a wide spectrum of prostate cancers out there. So unlike years past, we no longer treat all prostate cancers the same, and we'll discuss how we kind of sort out which cancers are aggressive and which are not. And we'll talk about the role of active surveillance or monitoring for low-risk cancers, which is something that's more commonly performed today. We'll discuss some of the controversies and update where we're at with screening for prostate cancer today. And then finally, we'll discuss, should you consider routine screening for prostate cancer? So just some background information to begin. Prostate cancer certainly remains a major public health problem in this country. As of last year, it was the most common cancer in men in this country, with about 180,000 men who were diagnosed. It was the second leading cause of cancer death in men in this country, with approximately 26,000 deaths attributed to prostate cancer. Risk factors for prostate cancer include advanced age, family history, and specifically we're talking about men who have a first-degree relative, so a father, brother, or uncle would be most concerning, particularly if they were diagnosed at a younger age. And then African-American race is also a risk factor for prostate cancer and a risk factor for more aggressive prostate cancer. There's about a 15% lifetime risk of being diagnosed with prostate cancer in this country. So approximately 1 out of 7 or 1 out of 8 men will be diagnosed with prostate cancer over their lifetime. And there's about a 3% lifetime risk of dying of prostate cancer. One of the other important things to understand about prostate cancer, it's typically asymptomatic. It doesn't really cause any symptoms until it reaches a stage where it's advanced and typically incurable. So in order for us to diagnose prostate cancer at a time where it is potentially curable, we do need some test or biomarker to make that diagnosis at the time we can do something about it. So just to make the point, usually there's no symptoms. I see a lot of men who come in to talk about their prostate cancer, and I have some guys who really struggle accepting that they have prostate cancer. They feel fine, they have no symptoms at all, and they really have a tough time accepting that that's what's going on in their body. But after some explanation, usually they come to an understanding. And men who do present with symptoms, difficulty urinating, blood in the urine, pain, weight loss, these type of symptoms, that's typically going to develop at a very advanced stage when the cancer is usually going to be incurable. So what tests do we use to find men who are at risk for prostate cancer? Well, there's two major tests that we've used over the last few decades to help diagnose cancer at an earlier stage. One is the prostate-specific antigen, or PSA blood test, that many people here may be familiar with. The other is the digital rectal exam, or the dreaded finger exam. Those two tests have really been crucial in helping us to diagnose these cancers at an earlier stage compared to what we were able to do a few decades ago. There are some other tests that we're starting to now incorporate into the early detection of prostate cancer and using them more selectively, although their role is still evolving right now. The only way to definitively make a diagnosis of prostate cancer is to do a prostate biopsy. So once we identify men who are at a high risk for prostate cancer, whether it's based on their PSA, their rectal exam, those men are typically recommended to undergo a biopsy. And a prostate biopsy is an office-based procedure performed by a urologist under a local anesthetic. We do use an ultrasound probe that's placed into the rectum to visualize the prostate and help direct the biopsy needles into the prostate. And typically it's well tolerated and has a low risk of complications. I won't pretend to tell everybody that there's no discomfort involved, but it's fairly similar to what people would experience maybe when you go in for a dental procedure. My wife's a dentist, so we always kind of kid about who their patients hate coming to see more, me or her. But most people will tolerate this procedure quite well as an office-based procedure. Prostate cancer diagnosis. Once we do make a diagnosis on a biopsy, there's more information that we find, not just is there cancer present or not. And one of the key things that we find is the grade of the cancer. So the grade is an estimate of the aggressiveness of the cancer, what its potential for growth is, understanding that higher grade tumors are going to grow quicker and have a higher chance for spreading to other parts of the body. Traditionally, we've used what's called the Gleason scoring system, which was developed back in the 1970s and has undergone modifications over time. It does get pretty confusing, and because of that, there's been a movement over the last couple of years to use what's called prognostic grade groups. And the prognostic grade groups are really just a direct translation of the Gleason scoring system into a more intuitive and easy to understand scale from 1 through 5, 5 being the most aggressive tumors and the group 1 tumors being the non-aggressive tumors. The stage of the cancer is something we also want to assess. That is a measure of how advanced the cancer is at the time of diagnosis. And once we have those pieces of information, we use that information to base our treatment recommendations. What about the staging of prostate cancer? Well, like many cancers, stage 1 and stage 2 cancers are localized cancers confined to the prostate itself. These are cancers that are curable. Stage 3 cancers are locally advanced cancers, so these are typically going to be cancers that are just starting to grow outside the prostate, but not to other parts of the body. These cancers still have the potential for being cured. And then we have stage 4 cancers, which for prostate cancer we can divide into lymph node positive prostate cancers, which are cancers just starting to spread into the regional lymph node areas in the pelvis, and then distant or metastatic prostate cancer to other sites in the body. And the stage 4 cancers are typically unable to be cured. So what tests do we use to stage prostate cancer? Well, the rectal exam is actually very helpful. So if we do feel a palpable abnormality on the prostate, we can make an assessment. Do we feel like that's confined to the prostate or starting to grow outside the prostate? So that test in and of itself can be very helpful. For many men, they don't need other tests done. Most prostate cancers that are caught early and are lower risk, there's not a high risk that the cancer is going to be someplace else, and so we don't necessarily have to proceed with additional testing in everybody. But in those high-risk individuals, there are other tests that we typically do recommend to look both at the skeleton or the bones, and then usually the pelvis and sometimes the abdomen to look for enlarged lymph nodes. And there are various tests that are used. Traditionally, we've used bone imaging and a CAT scan, but now we are starting to use some other imaging modalities for looking for bone metastases and even some promising PET scan imaging that we're now starting to do. So I mentioned at the beginning of the talk that we know that not all these prostate cancers are the same anymore, right? So 10 or 15 years ago, when we would diagnose prostate cancer, they were all thought to be lethal and they were all treated very aggressively. These days, we're much more sophisticated in our understanding that some of these cancers are very slow growing and may progress very, very slowly over time, whereas other cancers may be more aggressive and then everything in between. And so how do we figure out which cancers are more aggressive and which aren't? Well, we use a lot of different pieces of information that we get. So traditionally, we've used the PSA level, the grade of the cancer, the stage of the cancer, but we also look at the number of biopsies that are positive, the percentage of each biopsy that's positive, and the PSA density, which is a relationship between the PSA value and the size or volume of the prostate. So all these things have been shown to be very predictive of how aggressive these cancers can be, and we can, again, put men, once they're diagnosed, into these different subgroups of prostate cancer, and our recommendations to them are much more personalized based on which subgroup they're in. So we have made progress there without a doubt. Whenever we're talking about the management of prostate cancer, or any cancer really, it's important to understand the natural history of that cancer. And by that I mean, what would happen to that cancer if it was left untreated? Okay, I think that's always a very good question to ask when a patient comes in and they're talking about their cancer, when they ask, well, what if we did nothing? That's always important. That's a good baseline question to ask. Like most cancers, prostate cancer likely develops as a precancerous lesion and then proceeds to a localized cancer. Again, when it's potentially curable, it doesn't cause any symptoms. And then depending on the aggressiveness of that specific cancer, it gradually may progress to metastatic disease that spreads to other parts of the body and becomes incurable. However, we know that for some cancers, while that may happen rapidly over the course of just a couple of years, there are other cancers where it may take even 2+ decades for that to occur. So when we're assessing these prostate cancers, that's what we're trying to determine, again, when we look at the low risk versus the higher risk cancers. Once a cancer does spread to other parts of the body, initially if we saw some lesions starting to pop up on the bone or in the lymph node areas, usually that's still going to be asymptomatic, but over time those lesions, as they grow, can cause pain in the bones. The lymph nodes can enlarge and block the flow of urine from the kidneys, so we can start to see men suffer and have a decline in their quality of life, which ultimately is really what we're trying to prevent. There are a couple phases of metastatic prostate cancer. Most prostate cancers, when they're diagnosed, are sensitive to hormonal treatments, which is typically the first line type therapy that we use for prostate cancer. At some point, though, all prostate cancers will develop a resistance to that therapy and subsequently require other therapies. And if men live long enough, there is no cure for metastatic prostate cancer. Eventually it will lead to death. When we're talking about treatment of prostate cancer, we have two major goals. Number one is cancer control, and I don't like using the word cure a whole lot. I like the term cancer control here because really what we're trying to prevent is the development of symptoms, pain, or death from prostate cancer. And if I've got a man who's got a really low risk, slowly growing cancer, I've got an older man whose life expectancy might be shorter, we might be able to achieve that doing nothing at all except monitoring their cancer. And that might be a very good cancer control for that individual. Conversely, if I've got a guy who's 50 years old and has an aggressive cancer, we know we're going to need some curative treatment to prevent him from developing that pain and suffering. We also want to try and preserve quality of life, which is a close second goal. So we want to minimize any risks of treatment or management of the cancer so that a man can live as normal of a life as possible with regard to things like urinary function, erectile function, and bowel function. So I want to shift gears just a little bit here and talk about prostate cancer early detection and screening. And this has been a controversy that's been going on for a long time. Anybody here who's just paid attention to the news on a regular basis may see how confusing it is, because one day you might pick up the newspaper or get online these days and find an article that's talking about how prostate cancer really is not that lethal at all and we shouldn't be screening or doing PSA tests. Nobody dies of prostate cancer. And the very next day you read an article about how it's the second leading cause of cancer death in this country and the pain and suffering that men endure who develop metastatic prostate cancer. So it gets pretty confusing when you're just out there reading this article and that article. And I think it's been confusing, quite honestly, to a lot of primary care physicians out there as well, trying to figure out what's the right thing to do. So why do we have this controversy? Well, just some historical information and background first. So prior to using the PSA test, when we could detect prostate cancer early, you go back to the 1980s, prostate cancer was difficult to diagnose at an early stage. About a quarter of men who walked in the office and had prostate cancer already had metastatic disease. And only about 50% of men, or less than 50% of men, actually had confined cancers that were thought to be curable. So again, we had this great need for some tests that could help us find these cancers early. And again, that test was the PSA. So as we move into what's termed the PSA screening era, and as soon as, at least in the United States, as soon as this test was proven to detect prostate cancer early, it was widely adopted in this country for the most part. So from the early 90s into the mid part of the last decade, what we saw was a significant decline in the death rates of prostate cancer by about 40%. And that sounds like a pretty good success story. The problem was that it's hard to say that that was all due to early detection or PSA screening. And in fact, in other countries around the world that weren't routinely doing PSA screening, there also were some countries that saw a significant decline in the death rates of prostate cancer. So it was felt that this might be due to multiple causes, and there were some critics out there who said, well, whoa, 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 before we just hail this PSA test as the greatest cancer test ever, we need to kind of sort this issue out. What we did know is toward the middle and latter part of the last decade here, at the height of the PSA screening era, we knew that more than 85% of men were now presenting with localized cancer that were potentially curable. We had a decrease in the rates of high-risk cancer, and less than 4% of men were now presenting with metastatic cancer at their initial diagnosis. So again, that all sounds very impressive. But the problem was there was concern about over-treating a lot of these cancers. So as we started screening all these men, and again, historically, prostate cancer was felt to be just a lethal disease because those cancers that were diagnosed that became symptomatic were cancers that ultimately led to death in a lot of cases. So it was thought that all these cancers are going to cause men to die. Well, what we now know is many of those cancers that we were picking up very early, again, were some of these slower growing cancers which may not have been deadly to men, and so now there was this concern that we might be over-treating men. And so the dilemma was, now we've got this PSA test and we know we can pick up prostate cancer at an earlier stage when it's curable, but because prostate cancer can be a slow-growing disease and oftentimes is found in older men that may have other medical problems, it may not always be life-threatening. And so again, there was this risk or concern about over-treatment. And again, if you go back 10 or 15 years ago, most all prostate cancers were treated and treated aggressively. So you could potentially see that men could be harmed if they underwent treatment that ultimately they didn't need and might have suffered some consequences from their treatment. So the real question we were trying to answer then was, are we doing more good than harm or more harm than good by screening? And so we tried to answer that question, and I don't want to bore you with a lot of data, but just so you have some background information and then we'll kind of summarize things. You know, initially there were some observational retrospective studies. These are kind of lower level evidence type studies. They were conflicting and didn't really help us answer the question. And in 2009, there were 2 studies that were initially published that started to lend some real good information for us as far as how useful PSA testing might be, and to some degree just fueled the controversy a little bit as well. So the first trial, and the largest trial, was a big trial in Europe with about 180,000 men, ages 50 to 74, and they were screened with PSA tests about every 2 to 4 years depending on the site that they were at. If their PSA was over 3, they were recommended to undergo a biopsy. The initial results, again, were reported in 2009 with about 9-year follow-up, and then we've had further reports out longer now. And one thing I would point out here is, of the men who had a positive test and were recommended to undergo a biopsy, 86% of men did undergo a biopsy. So there was pretty good compliance with the recommendation to go forward and get diagnosed. And that's important. We'll compare that to the other trial here in a minute. Ultimately, what they found was there was an approximately 30% decrease, which was a statistically significant decrease in the death rates of prostate cancer for men who were screened with PSA in this test. And about 40% fewer men were diagnosed with metastatic disease who had undergone PSA screening. So that came out and that sounded like a very positive test, and it was, but again, there were critics out there who said, well, wait a minute here. How many men do we actually need to screen? How many men do we need to treat to be saving those lives? And at 9 years, when this study was first reported, it took about 1,400 men that would need to get a PSA test to save one life, and you'd have to treat about 48 men to save one life. So the concern was, are we still over-treating too many men, and is that worth saving the lives we're saving? The important thing to keep in mind here is these numbers are time-specific. So as we started kind of following men out longer and longer in these studies, what we found is those numbers started going down, which was predictable. That's typically what happens. And you can see at 13 years, those numbers were about half of what they were at 9 years. And the point I'd make here is the folks who tend to probably reap the most benefits from PSA screening or early detection of their cancer are probably men who are going to live longer, because they're men who their cancer is going to catch up with at some point. The other trial was an American trial, the prostate, lung, colorectal, and ovarian cancer screening trial. This was not quite as big of a trial, but still fairly large, about 75,000 men, similar ages, 55 to 74. These men, the screening was done a little bit differently, where they got a PSA every year. One of the differences was, if they did have a positive PSA test, rather than recommending a biopsy to these men, they were just given the information and then went out into the community and had, quote, usual care. Well, that wound up causing a problem. We had a couple problems in the 2 cohorts of men here. In the screening group, the group that was supposed to get in the annual PSAs, only, well, less than half of men actually wound up having a biopsy. So if you're going to have a test and you're going to try and find out if it's going to save people's lives, well, for that test to be effective, you can't just get the test. You got to go make the diagnosis and then potentially be treated. And so if you only have less than half the men who are getting treated, that screening group now looks a lot more like a control arm because they're not doing anything different than the other folks are doing in the other group. There was a problem in the control arm too, because a lot of men in the control arm were already getting PSAs just kind of on their own or with their primary care doc. And actually there was data that came out just this past year as an update that showed that in that trial, in that control arm, these men who supposedly were not supposed to get PSAs, over 90% of those men actually got a PSA, whether it was during the trial or afterwards. So now you have all these men who were still getting PSAs, so still had the chance to find a prostate cancer and proceed with treatment. So what we had was a screening arm that was closer to a control arm that was closer to a screening arm. Obviously, we're going to be less likely to see a difference between those two arms, and that's exactly what they found. So in these two groups, they didn't find any difference in the death rates of prostate cancer over time. Although the authors did freely admit in their conclusion that rather than saying that this was a trial where screening versus no screening, that there was no advantage, what they said was that routine or organized annual screening was probably no better than what they called opportunistic screening. So it did tell us that maybe the way we were screening every man every year with a PSA was probably too much. We probably didn't need to be doing that. And the only other thing I'll point out from this study is that in a subset analysis, when they looked at just the men who had no medical problems, what they found is in those men, there was about a 44% reduction in death of prostate cancer in the men who got a PSA. So again, just going along with the common theme here that the younger, healthier men who were going to live longer probably were getting the most benefit from this test. Finally, maybe the best pure screening trial that we have is a trial out of Sweden with about 20,000 men, and these men were ages 50 to 64, so this is now a younger group of men. They got PSAs every other year, so not quite as frequent as the American trial, and in the control arm, only about 3% of men got a PSA. So this is probably, again, the best pure screening trial where we had a group that was getting PSA tests, and we had other folks who just were not getting the test at all. And ultimately, they found an over 40% reduction in the death of prostate cancer 14 years out from the trial. And the other thing that was nice to see was the number needed to screen and number needed to treat. Those numbers we talked about earlier, they were actually pretty darn low and consistent with what we see in other cancers where screening is commonly accepted. So all that data and all those statistics, and I know that's kind of boring stuff, so what can we actually say here? I mean, what do we take home from those studies? Well, I think there's a few things that we can say from those studies. Number one is prostate cancer screening can reduce prostate cancer death rates or mortality. We know that from 2 studies, and there's high-level evidence to suggest that. However, PSA screening does lead to an increased diagnosis of prostate cancer, and if we're not careful, can lead to an overdiagnosis and, more importantly, overtreatment if we don't watch it. The other thing I think we can say is screening every year in every man is probably not the best way to screen. The American trial told us that. So less frequent screening, or maybe focusing our screening on higher risk men, or maybe more of what we call risk-adapted screening. So for instance, when you go in and have a colonoscopy and get colon cancer screening, your doctor, if everything looks perfect, might say, look, come on back and see me in 10 years. If they found a couple polyps though, they might say, hey, I want to see you in 3 years or 5 years, and let's do this again. So depending on what they find, they might make different recommendations to you. And there has been some evidence that doing that with PSA testing might be helpful too. So if a man, for instance, who's 45 or 50 gets his first PSA and maybe it's 1.5, it's not that high, but it's maybe higher than average at that age, rather than saying come on back in a couple or a few years, that man might need to be tested every year and watched more closely. The other thing I think we can safely say is that we shouldn't be performing routine PSA screening in men with less than a 10-year life expectancy. So even in the studies that proved that PSA screening can save lives, we didn't see that benefit until about a decade down the line. So if we're screening men who have a 5-year life expectancy, we might find some cancers. We might find a PSA that's elevated and diagnose a cancer, but ultimately that man probably is never going to suffer or die of that cancer at all because it's going to take so long to cause him a problem. The other point I'd make is that the current data really still informs us fairly minimally about men who have a real long life expectancy. So when I sit down with a guy who's 50 years old and is going to live another 30 or 35 years, we don't really have the concrete data to sit down and tell him exactly what he should do. I think we can use a lot of this data to form a discussion, but again, the follow-up on these studies is still less than 15 years. So current guidelines and recommendations, there's a lot of medical organizations out there that make recommendations about cancer screening and prostate cancer screening. Most of these organizations, they're a little bit wishy-washy on PSA screening, and appropriately so, because I think they all make the point that it's probably not the right thing to do in every single man, but at the same time, they make the point that there can be some benefit for men as well, and they usually recommend some form of what we call shared medical decision-making between an individual patient and their physician, making the right decision for themselves, and we'll talk about kind of how we do that in a minute. The one thing I would point out is the United States Preventative Services Task Force, which is a group that makes recommendations to family physicians. In 2012, they downgraded their recommendation of prostate cancer. They used to give it a C recommendation, which was not really recommending strongly for or against, again, like a lot of the other medical societies here. But they downgraded in 2012 to a D recommendation. They were recommending against PSA screening. That's one of the reasons over the last 5 years, we now have data showing that there are higher rates of metastatic prostate cancer in this country, and we're seeing a lot more high-risk prostate cancer when it presents, and I'm certainly seeing that in my practice. And so I think a lot of that is because we're not screening as much. Just this past June, they amended their recommendation. So every 5 years, as a normal process, they reevaluate their recommendations that they make. And so in 2017, it was time to look at this again, and they changed it back to a C recommendation. And hopefully there's a lot of family physicians out there that will recognize that. I'm trying to get the word out to folks and at least realize that this is a test that has some benefit, it has some risk, but it should be discussed. It shouldn't just be recommended against necessarily. And I think there's two reasons why they changed their recommendation. One reason is that the information we talked about for the American trial, which again they kind of used to make their initial recommendations in 2012, once that data came out showing that 90% of men in the control arm were getting PSA tests or got a PSA test at some point, I think they realized that study was really tainted and it was hard to say this is a screening versus no screening trial. I think the other piece of information was it was pretty clear that in the United States we're now utilizing active surveillance or monitoring for lower risk cancers. And what that means is when we diagnose a prostate cancer, that risk of over-treatment is less if we're not aggressively treating every single man out there. So I think they felt more comfortable with what had changed over those 5 years to change their recommendation. So when I sit down and I talk to a man about PSA screening, ideally, how would we do that? Well, I think, number one, we need an assessment of life expectancy. So as I mentioned, men who have a shorter life expectancy may not benefit nearly as much as men who have a longer life expectancy. So we look at age, not the only factor, but one of the main factors. Family history, so has every person in their family lived into their late 90s and died of natural causes, or is everybody dying in their 50s from heart disease? And then other medical problems that that man may have. So once we can assess life expectancy, that's a key piece of information. The other thing that we want to assess, though, is an individual's preference and priorities with regard to their longevity and then their quality of life, urinary function, sexual function, and bowel function. And so I can have two men who come see me who might be 68 years old and have the same exact cancer, and one guy may come in and say, you know what, I've already got erectile dysfunction, I'm having urinary problems as it is, and oh, by the way, I've got a whole bunch of grandkids, and the most important thing for me is to be around as long as I can and watch these grandkids grow up. That's what's important to me. That guy's probably going to do very well to get screened with a PSA, because even if he finds a cancer, he's probably going to want to treat it. He's more concerned about his longevity. You take another 68-year-old guy with the same exact cancer who walks into the office and might be single, might be dating, his sexual function might be much more important to him, and he might place a much higher priority on his quality of life than his quantity of life. And that man might say, look, I don't want to go through a test and find something that, you know, might extend my life a few years. My priority is my quality of life at this point. So we really have to kind of assess that. It's not always so clear in every man. Those are kind of the two edges of the spectrum there. But assessing those priorities are important. Once we've assessed those two things, then I think, again, we can sit down as a physician and a patient and usually make a pretty good decision about whether to do this test or not. So that's the ideal scenario. The reality is that that doesn't happen, and there's a lot of reasons for that, but the main reason is primary care physicians just don't have the time, and I feel so bad for primary care physicians. They have so much on their plate these days, and there's just no way, you know, we're sitting here having a conversation for an hour about this stuff. They just can't do that, and oh, by the way, make sure somebody's heart's okay and their cholesterol's okay and their blood pressure's okay. So it's very hard for them to fully educate people. As the prostate cancer program here, we're trying to assist primary care physicians and see what we can do to help get educational materials out to patients that they can read and really just become educated about this, similar to what we're doing at this seminar here. So ultimately what happens? Well, I think two things happen. Either physicians don't test at all, or physicians might still test routinely on a yearly basis. That's most of what we're still seeing, one way or the other. And the problems with that are if we just abandon PSA screening, well, we kind of go back to where we were 3 decades ago. We're going to have more men presenting with metastatic disease and higher risk cancers, and as I mentioned, we're already starting to see a little bit of that now. Or we could continue with yearly annual screening where it's just routine on a lab panel that you get every year. The problem with that is there's going to be this risk of over-diagnosing men and potentially over-treating men. So obviously what we ought to be doing is trying to improve upon what we've learned and do things better. So how do we improve the risk-benefit ratio of PSA screening? That's really what it comes down to. Well, there's a few things that we can do. We can improve our biopsies. We can reduce the number of unnecessary biopsies, okay? Better tests to find out who really needs a biopsy. Combining imaging with biopsy techniques to biopsy more selectively and in a more targeted fashion. And we'll talk more about MR ultrasound fusion biopsy, which is now available here. Reducing the risk of infection, which is one of the main risks of a biopsy. And in today's world where antibiotic resistance is a bigger concern, there are multiple ways that we try to reduce that risk. Improving treatments. So again, all of our treatments, we're constantly trying to improve those treatments and improve the side effect profiles of those treatments. But I think the biggest improvement in the care of men with localized prostate cancer over the last decade has been the increased use of active surveillance and monitoring the low-risk cancers. And the distinction here between overdiagnosis and overtreatment is very important. So historically, one of the reasons why people would argue against PSA screening was they said, again, we're going to potentially do more harm than good. We're going to diagnose all these cancers, and these men are going to be diagnosed with cancers that may not be life-threatening. All these men are going to get treated and suffer side effects from the treatment. These days, just because a man's diagnosed with prostate cancer doesn't mean they're going to go through that treatment if we don't think it's going to benefit them. So understanding that most prostate cancers have this prolonged natural history, it takes a long time for it to progress to this symptomatic stage, and that prostate cancer is more common in older men who may have other medical problems. Whenever I sit down with a man who's diagnosed with prostate cancer, the first question I'm asking myself is, do I think this man is going to die of prostate cancer or something else? And sometimes the answer to that question is very easy and straightforward. Oftentimes it's not. We're obviously not perfect at predicting how long men are going to live, and we're not perfect at predicting how long it's going to take the cancer to progress, but we're getting a lot better at it. So a lot of people have heard most people die with prostate cancer, not from prostate cancer. Well, there's many reasons for that, but it does appear to be true that there's a significant percentage of prostate cancers that are these low-risk cancers that are not life-threatening. And we have some trials in men with low-risk cancer where they looked at treatment versus just monitoring their cancers, and at 10 years, there really wasn't a big difference in their survival. So these low-risk cancers really, truly grow very slowly. And when we talk about active surveillance, I should clarify exactly what we mean by that. So there's an older term called watchful waiting, or not an older term, we still use it, but something that was used much more commonly, which maybe in older men, we might monitor their cancers, and the only thing that was going to cause us to treat them was if they developed symptoms from it. So we're not trying to cure their cancer, we're just trying to palliate them basically and see if we can get them to live out their life and not develop pain and suffering. Active surveillance is different. This is where we're monitoring these cancers by following their PSA levels, repeated rectal exams periodically, and repeat biopsies, and the idea is still to catch these cancers when they're still curable, but not necessarily treating men until we really need to treat them. So if we have even a young man who's diagnosed with a low-risk cancer, I've got a large group of guys in their early 50s in my practice who have prostate cancer, and we're monitoring those cancers. And you might say, well, heck, that seems kind of scary because these men are going to live a long, long time. But if they aren't going to need treatment for a decade or so, and they can still be cured at that point, maybe we could get them another 10 years of really good quality of life before they have to take on any of the risks of those side effects, right? So we're really starting to expand the role of surveillance and monitoring of prostate cancer and trying to do it most appropriately. It's important to understand this is not an option for everyone, though. Okay? There are lethal prostate cancers out there, absolutely, and those cancers we want to treat aggressively. The low-risk cancers, though, or in men who have shorter life expectancies, again, this might be the preferable approach. So the advantages and disadvantages of surveillance are, number one, it avoids or at least postpones the side effects of therapy, such as urinary problems, erectile problems, bowel problems. The disadvantage is there's currently no absolute way to predict with 100% certainty that cancers are not life-threatening. So we're getting much, much better at this, and I'll talk about kind of how we do this in a minute, but any man who we sit down and decides they're going to proceed with surveillance has to understand there's at least still some small risk that we could miss that opportunity to provide them cure. So how do we do it then? Well, I think the most important thing is patient selection. Matching surveillance to the right patient is key. We are looking at lower risk patients, so these are typically patients who have a lower PSA under 10, a confined cancer, either a normal rectal exam or a very small lesion on their rectal exam, low-grade cancers, and usually not high-volume cancers. These are the men who are going to be best candidates for active surveillance, and in fact, these men who are diagnosed in what we call the very low-risk group, the National Comprehensive Cancer Network, which is a group that makes recommendations about treating cancers, will make the recommendation that active surveillance is the preferred approach in this very low-risk group of men who have a life expectancy of less than 20 years. So it's very much accepted and it's very much a standard approach for certain men with prostate cancer. Once we've diagnosed a man and we've selected out the right man and he says, yeah, I'm interested in surveillance, that sounds like a better approach for me, before we just start doing surveillance, they have to understand that if we go ahead and if we had 10 men diagnosed with low-risk prostate cancer and we took all of them to surgery, for instance, and took their prostate out, up to 3 or 4 of those men actually may have a little bit more of an aggressive cancer when we look at the whole cancer. So maybe there's something in there we might have just missed on the initial biopsy. So how do we make sure what we think we're dealing with is what we're dealing with? I usually call this the gateway to surveillance. The man's still got to pass one more test before they're a good candidate for surveillance. And what we'll typically recommend is that men undergo an MRI of the prostate within about 6 months, and then we repeat a biopsy with some more extensive sampling, and if there's a lesion on the MRI, we target that area. There's data out there that shows that we can cut down the risk of misclassifying a patient from that 30 to 40% range down to less than 10%. So that provides a lot of reassurance for the physician. It provides a lot of reassurance for the patient that surveillance is indeed probably the right thing to do. And if we find something more aggressive, obviously we can change our approach. There is genomic or molecular testing that's available now. I use it selectively personally. There are a lot of urologists who use it much more routinely in this situation. And these tests basically look at some of the molecular aspects of the actual biopsy tissue to predict which cancers might be more aggressive than others. And there is some data suggesting that these tests can be useful. I'm just not 100% convinced that data is enough for me to hang my hat on every single time I'm counseling a patient. And there haven't been any studies that compare it to using the process we're just talking about of using an MRI and a repeat biopsy necessarily. So I think we're starting to see these tests and they're starting to find their role, but those roles haven't been clearly defined just yet. Once we're providing surveillance, what do we do? Well, it's usually a PSA and a rectal exam about every 6 months or so, and we'll usually repeat biopsies about every 1 to 2 years, depending on the concern of the physician or the patient, either as a protocol, kind of routine biopsy, or certainly if we saw something clinically that raised concern that something was changing, we might do that a little bit sooner. What would cause us to change our approach? Well, indications for intervention from a clinical or a medical standpoint are if we found a cancer that had a higher grade on a subsequent biopsy, or we found a higher volume cancer now, if we were moving out of that low-risk group, we'd probably change our approach, again, depending on the age and the life expectancy of that patient. So there are some men who might be in their late 70s, and if we saw them now developing a little bit more of an aggressive cancer, it still may be that their life expectancy is such that that cancer is not still going to be the major issue for them. So we always, again, have to look at the big picture. The problem with active surveillance traditionally has been that there was fairly low physician and patient acceptance with it. And again, that was just out of the concern where physicians didn't feel confident that they could predict which cancers were low risk or not, and patients, because their physicians didn't feel that confident. Nowadays, that we can do a much better job at predicting which cancers are low risk, physicians feel more confident. I think patients do too. In Greensboro, we've strongly embraced active surveillance for low risk cancer. And I'm actually looking at our patients who are diagnosed in the Cone Health System this year as a project I'm doing, and I've been very impressed that we're using that very appropriately. So I think we're not over-treating men in our community. So what is new out there for diagnosis and treatment? So a couple of things. A couple of years ago, I did this seminar, and one of the things I mentioned at that time is I thought we were going to be doing a lot more MRIs of the prostate, and indeed that's become true. So with some of the improved techniques, the improved experience of radiologists who specifically are trained to read these MRIs, and we now know that the MRI of the prostate is approximately 90% sensitive for finding high-grade cancer. So this is a really good test for finding that cancer that might be a threat to a man's life. It's actually pretty poor at finding low-grade cancer, which is fine. Those aren't the cancers, quite honestly, that we want to find, because those are the cancers we're probably just going to monitor anyways. So I think this test can be very useful for us. It's currently approved in men who have had an initial biopsy that was negative, but their PSA keeps rising and we still have concern. Or again, we use it in those men with low-risk cancers where we're trying to really figure out, is this a low-risk cancer or not? Insurance companies will pay for that pretty regularly now. I can foresee a time where we change our approach, and maybe every man who gets a PSA subsequently gets an MRI before they get biopsied. And we'll talk about that a little bit more here in a minute. We also now have the ability to do targeted biopsies. Prostate cancer is probably the only cancer I know of where when we do a standard biopsy, we're just systematically sampling the prostate. We're not necessarily targeting a lesion or a spot that we saw in an imaging study. Using MRI, we now have the ability to do that, and we can either do that with what's called cognitive fusion, which is basically just, you know on the MRI where the lesion is, and when you do the biopsy, you're just taking additional samples of that area. Or now what's called MRI ultrasound fusion biopsy, which is basically where we can take the MRI images and use software to fuse that image with the ultrasound image, so that when we're doing the biopsy under ultrasound guidance, that image is popping up right there on the ultrasound image, and we can see the needle going directly into it. So again, these are some of the newer things that are out there in terms of diagnosis, and I think we'll continue to see that role evolve and probably widen over time. How about treatment? What's new for treatment? Well, the biggest advances for prostate cancer treatment over the last decade have been for advanced or metastatic prostate cancer. If you go back before a decade ago, we basically had two treatments that were helpful for managing men with prostate cancer. One was hormonal therapy, which had been around for over 50 years. And then we finally had a regimen of chemotherapy in 2004, which was demonstrated to improve survival in men with prostate cancer. In the last 8 years, we have about 6 other new therapies that have been developed. They're all different types of therapies, and they've all been shown to extend survival in prostate cancer. And I think that's important for 2 reasons. Number one is it's helped to extend the life of a lot of men with metastatic prostate cancer and delay the onset of symptoms. But it's also helped us, for these men who have low-risk cancer, who might be considering surveillance, to feel more comfortable with that approach, knowing, hey, we got this much wider safety net now, and hey, if this cancer did progress and we had to do something about it, now I got a lot more options on the table than I did previously. And so with all these treatments being developed, the natural next step, and this is really the newer information, was trying to combine these therapies to see, hey, would the combination work better than each of the individual treatments in sequence? And so 1 year ago, there was a trial that looked at adding chemotherapy up front with hormonal therapy to men who had metastatic prostate cancer, and that showed about a 15-month survival advantage when we used chemotherapy earlier. And just this past June here, there were 2 studies that demonstrated that using a medication called abiraterone, which is one of these oral hormonal therapies that works a little bit different than standard hormonal therapy, when you combine that with standard hormonal therapy, we see a significant reduction, about 38% lower risk of death in prostate cancer. And actually, in the main study that was just reported, we haven't seen the median survival reached yet in that group of men who are getting combination therapy. So this is going to be a new standard of care for most men with metastatic prostate cancer now. So we're starting to see a lot of things change for men with advanced prostate cancer. And when I used to sit down with men and they had metastatic prostate cancer, assuming they're going to live for more than 5 years, you kind of knew that prostate cancer was going to be the thing that was going to kill them. That's not true today. All these advances have made it so that we can sometimes treat these cancers and let men live out their lifespan. True, each of these treatments has their own side effect profile, but that's better than pain, suffering, and death. So what about the future? How do we continue to improve prostate cancer care? Well, ultimately, we need better tests to detect clinically significant prostate cancer. We'd be better off if we were doing less biopsies and just biopsying the men that we thought had these higher risk lethal cancers and not finding these cancers that are not going to be lethal. So as I mentioned, I can foresee a day where maybe in the not too distant future, if a man has an elevated PSA, maybe we then, before just jumping in and doing a biopsy, maybe we do an MRI. And if the MRI is normal, maybe we watch that PSA. If the MRI is abnormal, maybe then we go ahead and we biopsy it and we target that specific area. I can foresee a time where we would be doing that. But we need more data to make sure that's truly advantageous. Better biopsy strategies, so again, targeting these lesions will be helpful, and better utilization of active surveillance. So we're doing a much better job of that now than we were even a few years ago. But we can still do better in trying to not treat the non-aggressive cancers, but treat aggressively the aggressive cancers. And I want to make sure I'm not, we've talked a lot about this surveillance or monitoring for prostate cancer, and I think it's important. It's not to say there aren't a lot of prostate cancers out there that are very aggressive and need aggressive treatment. So I just want you to understand there are different types of prostate cancers out there. And although we used to treat all of them, now we're starting to do a better job of separating them out. And we treat some of the really aggressive prostate cancers even more aggressively than we used to, because that's what those cancers need. Some of the middle cancers here, maybe we're treating them, but not quite as aggressively as these higher risk cancers. And then these low risk cancers, maybe we're just monitoring them. So we're trying to personalize our care and individualize that care the best we can. Certainly there's always room for improving the current treatments that we have or developing new treatments to decrease the side effects of those treatments. So prostate cancer early detection or screening, what should you do? Well, I think the most important thing is doing exactly what you're doing tonight. Coming out here, becoming educated about prostate cancer and the pros and cons of screening, and figuring out what is the best thing for you as an individual. I think as far as just general statements, we can say, again, men who have a less than 10-year life expectancy, so this would include most, not all, but most men who are 75 or older, men who might have significant health problems. Again, I would not recommend routine PSA screening. I have a lot of men in my practice where we've been monitoring their PSA for years and years, and they might be in average health at age 75, and their PSA has been normal forever, and we talk about stopping it because it's not necessarily going to be a useful test. It may lead us to find a cancer that we don't even want to find and put a man through unnecessary procedures and complications. Men who have risk factors for prostate cancer, so these are men who have again, first-degree relative or African-American men, should proceed with routine prostate cancer screening, and probably starting in their 40s would be the time to do that. Men who have a greater than 20-year life expectancy who otherwise are at average risk, I would strongly consider routine PSA screening, but I think it requires a little bit of a discussion like we're having tonight. But those are the men who are going to benefit most. Remember, all the studies we looked at, the men who are going to live longer seem to reap the most benefit from being tested and potentially treated. And then those men in the middle who have maybe a 10 to 20-year life expectancy, I would consider it, but I think you really have to weigh the pros and cons when you're in your late 60s and you're really trying to sort out what are my preferences, what are my priorities, what is important to me, my longevity, my quality of life, where is that right balance, right? And I think a lot of men sometimes will choose to be still screened and tested at that point, understanding that we're not going to overtreat these days, as long as there's a comfort level that they're seeing a urologist or a physician who doesn't overtreat cancer. I think people are a lot more willing to undergo screening just to make sure they don't have that aggressive type of cancer. So just to finish up and make a plug, this will be the 4th year that we have the Zero Prostate Cancer Run and Walk, and I think some people here see some familiar faces who have probably been out there in years past. We've raised a lot of money, both nationally for research in prostate cancer, and about half of that money that's raised stays right here in the community. We use it for our community early detection program that Christine runs and helping some folks who don't have access to health care necessarily. It's always a great event, and it's been getting bigger and bigger. We have one of the better races actually around the country. We have other people coming to talk to Todd Pittman, who's our administrator, who really sets up the race to figure out what he's doing, because he seems to do a very good job with these races. But it's a fun time, and I'd encourage people to come out. It's November 18th, which is the Saturday before Thanksgiving. Thank you very much. As far as how that affects prostate cancer and testing? Right, so those type of medications, there are men who are on medications like Avodart or dutasteride or finasteride, which actually shrink the prostate. One of the things that can cause the PSA to be elevated is just the size or the volume of the prostate. So men who are on these medications, you have to understand that as your prostate shrinks down, your PSA is going to be lower. And we have to account for that when we're testing men and we're monitoring them for prostate cancer. So for instance, if your PSA was 2 before you started Avodart, and then it went down to about 1, that would be kind of expected. And if the PSA went up to 3 while you're on Avodart, well, we have to understand that actually your real PSA is probably a lot higher than that, and that would raise additional concern. So we just have to account for the fact that those medications can affect the PSA value when we're screening or testing for prostate cancer. Does that make sense?
I'm not sure, but how long do you take that Avodart?
Well, it varies. I mean, again, we're talking more about enlarged prostate than prostate cancer, but for a lot of men, they'll take it lifelong. It can not only prove beneficial for just managing symptoms of an enlarged prostate, but it actually can reduce the rates of ever needing surgery for an enlarged prostate or having complications related to that. So it does have a preventative benefit for men with enlarged prostate as well. Sure, I'm sorry. The question was for men who are on 5-alpha reductase inhibitors, which are medications such as Avodart or Proscar or dutasteride or finasteride that shrink the prostate, how might that affect screening or testing for prostate cancer and their enlarged prostate? Okay, now I saw another hand. Yes, sir.
Dr. Borden, do you think that, or what is the current medical opinion on aggressive cells? Do they start out as aggressive, or do they become aggressive more over time?
Right. So that's a very good question, and the answer is we don't have a definitive answer. I think there's a lot of there's people who think both ways. Let me say that, and there's not a clear answer. So we think that there certainly are some prostate cancers that just are inherently more aggressive and begin that way. Okay, there's no doubt about that, and there are some low-grade cancers. But when we talked about monitoring some of the low-grade cancers, one of the things we're monitoring for over time is to make sure that those cancers don't subsequently become more aggressive, right? So I think there are certainly some cancers that start off as lower grade and might become higher grade. There are some cancers that probably just start off as being very aggressive, and it's probably based on genetics or other environmental factors that may tip that off. So I think we see a little bit of both, but the honest answer is I don't know, because there isn't clear evidence to suggest either way, but I think there's probably a little bit of both. We've learned over the years that prostate cancer is just a very heterogeneous disease. We see, I think, when we sit here and we talk about prostate cancer, 20 years from now they'll probably laugh at us and they say, oh, they called all those just prostate cancer, and they'll lump them in together. We're going to start probably looking at these cancers based on their genetics, on their molecular profiles, and we're going to be classifying these cancers probably almost as different diseases, and then our treatments are going to be focused on that specific cancer or that specific cancer rather than just treating them all the same. Yes, ma'am.
There was a note up there about PSA doubling. Would you speak to that, like if the PSA doubles but it's still under 4? How does that?
Sure. So one of the things, good question, and the question is how might PSA doubling time or changes in PSA affect our recommendations, right? So when a man comes in and they have a PSA done, we don't act reflexively to that PSA, meaning if it's just over a certain number, we're going to do a biopsy, and if it's below that number, we don't worry about it. So if a guy comes in as PSA is 3.2, you know, are we going to do a biopsy? And if it's 2.9, we don't worry about it. No, we look at a lot of factors, and we try to really assess that individual's overall risk. We look at race, we look at age, we look at family history, prior PSAs that they've had done, and so we are truly looking at maybe the change in the PSA as much as we're looking at the actual PSA value. So if I've got a guy who has an enlarged prostate, for instance, who's had a PSA of 4 for 6 years and every time it's the same, I'm not too worried about that guy having prostate cancer. But another guy who comes in and his PSA is 3, but it was 1 the year before and 1 the year before that, it's really jumped up. I'm much more concerned about that man. So for screening purposes, that change can be very important. And then we also use PSA changes or PSA doubling time, how quickly the PSA doubling is very important in other aspects of prostate cancer. So for instance, men who have recurrent cancers, where we're trying to follow those cancers and determine, is this a cancer that we need to be more aggressive with our treatment and treat them systemically or with whole body therapy. If the PSA is going up very slowly, we may watch that cancer for a while knowing that it's not going to progress rapidly. But if the PSA is 2, then it's 4, then it's 8, then it's 16, and it's doubling every 3 months, we know where that's headed pretty quickly, and we'll go ahead and start treatment earlier. Okay. Yes, ma'am.
When you do the biopsies, you take a random sample of the prostate, 12, I think, and then they're all looked at, determine what they are, et cetera. And an MRI, would that not give you a better definitive picture of the entire prostate?
That's exactly why we're doing more MRIs. So, and I think what you're getting at is, and the question for the program here was, when we do a standard biopsy, and I don't like to use the word random, it sounds like we don't know what we're doing, systematic biopsies, okay, that's maybe a better term. But right, we're not targeting any specific lesion. Wouldn't we be better off if we were targeting a specific lesion? And I think the answer is ultimately going to prove to be, is going to be yes, but we don't have the data and the evidence right now to say that that's absolutely true. And one thing about MRIs is they're not cheap, so that adds cost to the care potentially, although I would argue that in the big picture, if we're finding the cancers we need to find when we need to find them, and we're not finding the cancers we don't need to find, actually the total cost of care might actually go down. There's been some data to suggest that. But I think ultimately that's probably what we'll be doing in the future, because prostate cancer, again, is the only cancer I know of where we don't routinely target an actual lesion when we're doing a biopsy on at least an initial standard biopsy. So I think it's coming. That's just my personal belief, but I think we'll be there maybe even within 5 years. Any other questions?
For patients who lack risk factors, is there a recommendation for beginning a baseline PSA?
As far as
age?
The age, yeah. Okay, so the question is, when would we recommend starting PSA screening if a man's going to do that? So the NCCN, or the National Comprehensive Cancer Network, their guidelines that they have out there suggest maybe getting a baseline PSA around age 45. So the screening trials that we looked at, all of them were men that were at least in their 50s. So if you're going to be a purist and look at the data, you'd say, okay, over age 50. The reason why the NCCN uses 45 as a reasonable time maybe to get the first PSA is because there is data suggesting that an initial PSA for a man in his 40s can be highly predictive of their future risk of prostate cancer. So if we took 100 men and we tested them all at age 45 with a PSA, we could actually immediately select out a group of men who we know are going to be at a higher risk for having prostate cancer at some future point in their life. It may be way down the road yet. And that's why we talked about that risk-adapted approach, where if the PSA is a little bit higher than average, not high enough where we'd recommend a biopsy, but a little bit higher than average for that age, we might say, hey, come on back next year, let's keep watching this closely. Whereas another guy, we might say, maybe we have to check it again in a couple years or 5 years down the road. But age 45 would be the time where we would at least start having the conversation.
I'll go tell all my friends.
There you go.
Thank you.
Yeah. Any other questions?
What are the risks of the biopsy?
I'm sorry, say that one more time.
What are the risks of a biopsy?
The risks of a biopsy, yeah. So the risks of doing a biopsy are usually like any other biopsy procedure that are done for other reasons. There's a small risk of things like bleeding or infection. The risk of severe bleeding typically is pretty low, but we do have some men who rarely might have enough significant bleeding that they need to be hospitalized. It's typically less than 1% of men in our experience here. Infection has been on the rise after biopsies nationally, and that again is based on the issue of antibiotic resistance. So antibiotics have really been overused in this country. Anybody who's here in healthcare knows that. And so there's been a real push to try and use antibiotics more selectively and more appropriately and not just willy-nilly for any kind of problem or somebody comes in with a cold. But because that has been common over the years, we have a lot more people who harbor a lot of these resistant bacteria. So what we've done, at least here in Greensboro, is again we assess a patient's individual risk. So if they come in and they're a healthcare worker, they're working at the hospital where there's going to be a lot of resistant organisms. If they travel internationally, or if they've received similar antibiotics that we would use within about 6 months, those are patients that we give a little bit more of a stronger regimen to before we do a biopsy. And again, our rates here in Greensboro are more around the 1% range. Nationally, in some of the big databases, it's more in the 4 to 6% range. There have been other strategies that people have looked at, some doing what's called rectal swabs, where you have patients come in a week or two ahead of time, and then you actually take a swab of the bacteria from the rectum and you grow out whatever bacteria is there, and then you target the antibiotic to that particular bacteria. So that's an approach that's been used. And then there are some people who are just using stronger antibiotics. The problem with that is that I think that's just going to lead to selecting out more resistant organisms as time goes on. I don't think that ever is going to play out well in the long run. It may help in the short term. And then the only other risk of a biopsy is not finding a cancer. So again, if these are microscopic cancers and we're poking needles in the prostate and we just don't hit the one little area that has cancer, there's a chance that we could miss a diagnosis. So that's why we don't just forget about a man at that point and say, look, you don't have to worry about this, go back and see your primary care doctor. We'll still monitor their PSA and monitor them clinically and make sure that we're not missing something over time. And again, if that individual has a PSA that keeps going up, that's the man where we can and currently do a lot of MRIs and then use the MRIs to do more directed biopsies if we're ever going to do a second biopsy. Okay? All right, those are all great questions. Any other questions? Okay, well, thank you everyone for coming out tonight. Appreciate you being here, and hopefully this has been educational. Thanks a lot.